That recording is going to begin now, and I'd like to turn the floor over to Lee Taggart. Lee.
Thanks, Patrick. Thanks, everyone, for joining us today. My name is Lee Taggart, and I know most of you, but I am an adjunct faculty at the university here. And I'm really excited today to have a longtime friend, Tony Banbury, joining us from Washington, D.C. So I've known Tony for, gosh, probably going on 45 years. I'm dating myself now. But Tony is the president and CEO of the International Foundation for Electoral Systems. And he joined this organization in November of 2018. But prior to joining IFES, Tony has had an extensive career working for the UN and the US government. So I'm going to read Tony's bio here. He worked for the UN for 20 years in a variety of roles, both at UN headquarters in New York and in the field. From 2009 to 2016, Tony served as the Assistant Secretary General for Field Support. In this role, he was responsible for providing operational support to more than 30 UN peacekeeping and political missions around the world, with a combined annual budget of more than $8 billion. And with more than 170,000 deployed personnel. While working at UN headquarters, Tony was given a number of special assignments by the Secretary General, including designing and leading the UN's first ever emergency health mission in response to the 2014 West Africa Ebola crisis, designing and establishing the Joint Organization for the Prohibition of Chemical Weapons UN mission to remove chemical weapons from Syria in 2013, leading the effort to stop widespread killings and prevent genocide in the Central African Republic in 2014, and leading the operational response to the 2010 Haiti earthquake, the worst humanitarian disaster in the Western Hemisphere in modern history. Tony previously served as Asia Regional Director for the UN World Food Program from 2003 to 2009, where he oversaw operations in 14 countries, including Afghanistan and North Korea, and led the organization's operational response to the Indian Ocean tsunami and Cyclone Nargis in Myanmar. Tony started his UN career in 1988 as human rights officer in Cambodian refugee camps in Thailand, and later served in various humanitarian, political affairs, and human rights positions in Asia, the Balkans, during the war in the former Yugoslavia and UN headquarters. Prior to his most senior roles with the UN, Tony worked in the United States government as director and then senior director for democracy, human rights, and international operations at the National Security Council from 2000 to 2003. And senior policy advisor in the Balkans Task Force at the Department of Defense from 1998 to 2000. He holds a master's degree in law and diplomacy from Fletcher School of Law and Diplomacy at Tufts University, a graduate degree in international relations from the Institut Université des Hautes Études Internationales at the University of Geneva, and a bachelor's degree in political science from Tufts University. He's a member of the board of directors of the Center for Public Impact and received a Distinguished Service Award from the President of the United States for service on 9/11, a Bronze Palm to the Exceptional Civilian Service Award from the Secretary of Defense, an Exceptional Civilian Service Award from the Office of the Secretary of Defense, and a Distinguished Alumni Achievement Award from Tufts University. Tony speaks a variety of languages, Tony speaks to varying degrees, French, Thai, and Cambodian. He lived abroad for more than 12 years in 8 different countries in Africa, Asia, and Europe, and has done working visits to over 70 countries during his career. So with that, I'm very pleased to turn it over to Tony Banbury to talk about his experience with the Ebola and how it affects the current pandemic. Thanks, Tony.
Hi, Lee. Well, thank you very much for that. You've now suitably embarrassed me by reading that entire thing. One bit of my background that's not on that long bio is, in some respects, the most important part, where I went to high school, which is the same high school that Lee went to. And since she embarrassed me so much by reading the whole thing, please, during the Q&A session, ask me if I know any stories about Lee from high school that she would not want me to share, and I'll be very happy to share those. It's a real pleasure to be here with you and addressing you on a subject that I do care a lot about, and I think there are some very important lessons from that really dramatic 2014 West Africa Ebola crisis that are very relevant to the domestic and international response to the COVID pandemic. And unfortunately, some of those lessons that were learned during the 2014 Ebola crisis are not being applied, and we're seeing the results of making mistakes now that we really ought not to be making. I thought, though, I would start, and we certainly will have Q&A time at the end, but I thought I'd start really by giving a short history of the Ebola crisis and how it developed, because I think having that historical grounding is an important foundation to just understand what happened afterward. And of course, in these kinds of situations, it starts with patient zero, and it's not 100% sure, but there's a strong belief that patient zero in the 2014 Ebola crisis was a 2-year-old named Emile Umwano, who lived in a village called Meliandu in the very rural areas of Guinea. And it's believed that Emile was playing or sitting around the base of a fruit tree with some of the other kids from the village, and that he probably, and it was a tree where a lot of fruit bats were, and he maybe ate a piece of the fruit that was contaminated by the virus from one of the bats. So Emile contracted Ebola and died in December of 2013. And within just a few weeks, his sister, his mother, and his grandmother all contracted the virus and died. Then there was a village midwife, kind of healthcare person, not really healthcare, this was a very remote village in Guinea, who contracted the disease, but she lived in a different village. And it then started to spread to neighboring villages from Meliandu, including through the health network or traditional healer network. And a healthcare worker who was infected passed it on to someone who went to a hospital in a town called Macenta, and that really got it into the public health network in western rural Guinea. So from January of 2014 to March, the virus really started spreading in a number of villages and got into this health network. And so doctors started getting it, nurses started getting it. And then in March 10th, one of these hospitals alerted the Ministry of Health in Conakry, the capital of Guinea. So that was their first official notification of existence. They didn't label it as Ebola because they didn't know it was Ebola at the time, but they reported a very serious disease with high levels of vomiting and diarrhea, and sometimes bleeding, and rapid death, serious death. The Guinea health authorities informed WHO on March 23rd, WHO and MSF, Médecins Sans Frontières, of this problem on March 23rd. So that's when the international community was first officially informed about this. Then it it really started to spread very seriously in that tri-border area where Guinea, Liberia, and Sierra Leone come together. And it was particularly dominant in rural villages and among traditional healers who were the ones often called upon when someone was sick with Ebola. A traditional healer would be called upon to help them, and then the traditional healer would get it. And one very well-known, well-regarded traditional healer contracted and died from Ebola, and had a funeral in May of 2014. And that funeral turned into a super spreader event in that tri-border region. And a relative of that traditional healer, I think it was a nephew, traveled from Monrovia, the capital of Liberia, to the funeral. And when he was there, he saw his sister, who was still living in the rural area, and the sister was sick, and he brought the sister from that rural area to Monrovia, a very densely populated city. And so there we see the movement of the disease from that rural tri-border area into the cities. And at this time, the virus by kind of April, May was just really spreading very fast. And I read an analogy once that it was like a peat bog fire, where you the fire's kind of taking place underneath and it's not very visible. And I think that's appropriate. It was spreading. There were like embers spreading all over the rural area, and that tri-border area, those borders didn't mean anything to the people of that area. They had relatives living on either side of the border. They had business going back and forth. And so there were no health controls, no really even border controls there. And the disease was spreading much faster than the public health community was able to respond. And the national authorities in initially Conakry and eventually Monrovia and Freetown did not take it seriously enough early enough. And certainly WHO did not take it seriously enough early enough. There was pressure from the government authorities, and this is one kind of theme that goes through this crisis and the COVID crisis, where politicians get involved and make decisions for the wrong reasons. And so there were pressures from the government in Conakry against on WHO not to declare a public health emergency because they were afraid it would be bad for business, bad for tourism, stigmatize the country. And WHO showed a lot of weakness in this initial response and succumbed to that pressure. And it wasn't until things were really getting out of control in August that WHO finally declared a public health emergency of international concern. That's a very formal designation done based on a recommendation of an international committee. And it came on August 8th. And so that Emile Wano died of Ebola in December, and it wasn't for 8 months until the WHO really started to treat this as the emergency it was. By then, though, so much time had been lost. The virus had spread into so many different parts of all three countries. And as a result, that effort to stamp it out was starting from a very bad situation. Had the international community taking the disease much more seriously in March, the response would have been very, very different. So on August 12th, just a couple days after WHO declares this public health emergency, the UN appointed an Ebola coordinator, a gentleman named David Nabarro, Dr. David Nabarro, a friend of mine, good guy. So David had a public health background, but not really a crisis background. And so David started going around consulting with capitals in the region, in Europe, Washington, and we probably lost another 3 or 4 weeks in August when consultations were taking place rather than like really serious fast action. And at that time, the case numbers were just shooting straight up. The TV was showing people dying on the streets outside overcrowded Ebola treatment centers in Monrovia and Freetown. The images that started to appear on international TV screens in late August of 2014 were very compelling and dramatic and horrible. And then I got brought into it in early September without any public health background. You probably noticed from Lee reading my resume, I don't have a public health background at all. I have a lot of crisis management experience. And so I was brought in on September 8th as Ebola crisis manager. And I quickly kind of assembled the team and started studying and trying to learn about what was going on. And it was really apparent to me that the crisis was out of control. There was no one in charge. There was no strategy to end the crisis. There was a heavy focus on the health aspects and almost a complete lack of focus on all the other parts of crisis management that were also going to be necessary. Strategy, planning, logistics, communication, that kind of thing. And so within about a week, the team that I was working with, we came up with an idea of creating, Lee mentioned it, the first ever emergency health mission. The UN had lots of peacekeeping missions, political missions, but had never done an emergency health mission. But it was apparent to me that there needed to be some place where all the planning could come together, all the organizing of the logistics, all the input, all the information. It needed to come together in one place. And so we proposed the establishment of this UN mission for Ebola emergency response, UNMIR. It was done in really record time. We went, I was appointed on September 8th, and on September 15th, a week later, we had this proposal to the Secretary General, and he approved it. 2 days later, it was in the General Assembly, and the day after that, the Security Council, no, the reverse, sorry, Security Council, then General Assembly. And by the end of the week, from the time it was proposed to the Secretary General on a Monday, it was approved on a Friday, and that is kind of really a record in the UN. And interestingly, the proposal in the General Assembly got more co-sponsors of, no, I'm sorry, it was the Security Council resolution got more co-sponsors than any other resolution in the history of the United Nations, in the history. The proposal to establish this emergency health mission. And so UNMIR was established, and the Secretary General asked me to lead it. And so a bunch of us got on a plane. We fly to West Africa, and it was really apparent when we landed that there was no plan to end the Ebola crisis. There was a lot of activity, a lot of NGOs there, good NGOs like MSF, Partners in Health, others, good NGOs doing good work, but the activity was very atomized, a little bit here, a little bit there. It focused for the most part on Ebola treatment centers, and there was not any overall strategy where things were coming together. And the activity was very atomized. And so we set about coming up with a plan, a strategy to end the crisis. And we had WHO as part of our mission, CDC was part of our mission, and we asked, like, okay, what, not being a public health person, what is necessary to end the crisis? Like, how are we going to break the back of this crisis? And we concluded, or the experts concluded, that we needed to get 70% of the people who are infected isolated, and 70% of the burials of people who die of Ebola done safely, because burials was such a was the main vehicle for transmission of the virus. And we were like, okay, 70, got it. What's 70% of what? What's the case still going to be? So this is late September now. And we said we needed to get those numbers, 70 in 60 days. So by December 1. And so we were asking the epidemiologists, all right, what's going to be the caseload? What numbers? And they really couldn't agree. And WHO and CDC had this big fight over the numbers, and they didn't want to give us any numbers. And we need the numbers. We need, because if we're going to have 70% of safe burials or 70% of the cases isolated, we need to know how many cots, how many burial teams, how many vehicles, how many liters of fuel, how many PPE suits, how much chlorine, all of everything we were going to do was going to be based on that 70-70 figure, but it needed to be 70% of something. So they finally came up with a number of 100,000, and so we're like, all right, we have the number. But that drove an enormous logistics train then, and it became very dramatic, what we were trying to flood into that zone. But at least we now we did this big planning conference, and we came up with a plan of what had to be done, everything that had to be done, logistics, communication, training, Ebola treatment centers, where they are going to be, all that kind of stuff. But there were a bunch of mistakes that were made also. There were some vulnerabilities to Ebola in that area. They had never seen it there before. It had been a disease basically in DRC and Central African Republic. That part of West Africa had not seen Ebola before. They didn't recognize it early enough. The way people moved about had a big impact on it. In the places that had been in DRC, they'd been kind of isolated villages, so the disease didn't move around so much. And then there were mistakes made early on around communication and messaging, saying there's no cure for Ebola. And people thought, well, if there's no cure, then I don't want to go to the hospital. I'd rather die at home. There was a mistake made around insisting that burials had to be done according to basically not even burials, either a lot of burning of bodies, but some burials, but done by outsiders, people showing up in PPE. And there was a very strongly held belief among a very significant portion of the people getting Ebola that if their relative was not sent into the next life in an appropriate way, that they would be unhappy, their spirit would be unhappy and cause unhappiness for all their living descendants. And so the idea that people would just be taken off by foreigners and burned unceremoniously absolutely freaked out the communities. And so people started having hidden burials late at night, and that created just more disease. So the communication with the communities at those early stages was done very poorly. And so when we showed up, there was so much going against us already, a real lack of trust against the people in the PPE suits, a lack of trust about messaging around safe burials, a lack of trust of the messengers. And so we contracted or hired an anthropologist who knew those communities very well, a British woman, and very quickly she started giving critical advice about the beliefs and practices of the communities that were most impacted and the best ways to communicate with them, which was clearly through local voices and trusted voices, not Westerners, not signs in English or French, but really local imams or village headmen or traditional healers. And so we put in place this plan. We changed the communications dramatically. We changed the burial practices and started letting families observe the burials from sort of a separation of like 2 meters, but the burial started involving religious leaders. And so we were able to really shift the trajectory of the crisis from that kind of mid-late September to December 1, that 60-day period, basically October, November, was that critical time where we broke the back of the crisis. And I didn't know if we were going to, like in September, October, I was scared to death that Ebola was going to spread everywhere, all over the world, concentrated population centers in Africa and Asia. It did spread a little bit to Nigeria, though the Nigerians were really effective in rapidly shutting it down. Huge kudos to them. But those of us who were involved in this in October of 2014, we were really scared, not of getting the disease, but that it was just going to spread everywhere. And this was going to be a huge global crisis with lots of people dying. Ebola is not nearly as contagious as COVID. It spreads by liquid, which is why the burials were such a big thing, because there was a lot of bathing of the dead body and ritual preparation of the body. And so those burials just ended up spreading the disease to so many. But while Ebola was not nearly as contagious, it was much more lethal. More than 1 in 3 people who contracted the disease died of it. It's about, in the end, it was about 28,000 people who contracted it and about 11,000 people who died of Ebola. Very, very small numbers compared to COVID, of course, but at the time they were quite high, and the risk that the virus would spread to other countries and urban centers, and that those numbers would go way up, was very concerning, to say the least. So what are the main lessons from the Ebola crisis? First, you definitely need a plan to end the crisis. As I said a couple of times, there was no plan, and so there was all this activity that was inefficient, wasn't going to achieve the intended result. When this mission, UNMIR, got on the ground, there was not even a stated explicit objective of, we need to end the crisis, stamp out Ebola. And that became our entire focus of effort. That was our one objective: stamp it out. And then everything drives toward that. But if you don't have an objective and a plan, you're going to maybe produce some good things like an Ebola treatment center here, some training activity there, but you're not going to achieve the objective that you haven't even managed to state. So that's the first key lesson. The second key lesson is that Ebola and COVID are not just health crises. They're partly a health crisis, but they are, or COVID is and Ebola was, much more than that. And you cannot rely just on the public health professionals to address the crisis. You need a crisis management approach with experienced crisis managers putting the strategy together and marshaling all the resources. The Ebola crisis became a lot about logistics, the building of the treatment centers and equipping them, and the PPE logistics, the fuel, the chlorine, the sprayers, the burial teams. There was a huge logistics component, and public health experts who are great at what they do are not necessarily trained logisticians. The communications piece, hugely important. Big mistakes early on, And so having strong communications experts who understand in this case, West African cultures, and not just some international PR kind of approach, but communications with a based on a solid understanding of the context. Very, very important. And I think we need to that crisis management approach also was very focused on getting good information, reliable information, and a single point of information. That information was so important to understand where to dedicate scarce resources. And without a crisis management approach and standardized information, getting people to agree on what's the definition of an Ebola case, an Ebola death, super hard because different countries, even different organizations were doing it differently. So coming up with that standard approach around epidemiological information was really, really critical for resource allocation. Another really important part of the crisis response was having an emergency operations center, essentially, which UNMIR helped set up in all three of the mainly affected countries, that brought together at a national level that crisis management approach. Before we got there, the presidents of the countries were having like daily meetings with their people, and you'd get like Alpha Conde, the president of Guinea, start making judgments about, oh no, why are these cars going here and these trucks going there? Like there was such a mismatch between what the presidents the information they should be getting and the decisions they should be asked for versus what the operations people should be getting. So without that strong crisis response, there were huge inefficiencies built into the system because you had literally heads of state getting involved in really small operational details, but not being presented with important strategic information or decisions that were required based on the information available. So these EOCs, these emergency operations centers, were designed to have the right people and entities involved in the appropriate issues. The engagement with the community, another really important lesson. It's related to communication, but having foreigners show up with PPE on, bright orange suits to say we're going to take away your dead relative and you're never going to see him again, you know, it just doesn't work. And so the communications, the community engagement, really important. The communication and trusted voice also important because there were a lot of rumors going around, misinformation, that the Ebola virus was sent by Bill Gates or Westerners in order to like harvest organs of dead people. And so the people who are trying to like take you to an Ebola treatment unit, they're just gonna, you know, you're gonna die there and they're gonna harvest your organs. And this is all part of some conspiracy theory. There was a lot of strongly held beliefs about total wacky conspiracies. So the communications part that was directly linked to the community was so important. Testing, of course, hugely important. Just like with COVID, the evolution of the testing changed over time, and it wasn't available at all early on, and then it became available, but it was hard to access, and it took a long time. The turnaround early on was about 7 days, and obviously that was way too long, and so we put in this huge logistics operation involving lots of guys on motorcycles with refrigerated boxes on the back to get samples from where they were collected into the testing center, and got down to 48 and then 24 hours, which was really, really fantastic. So the last part, our last subject I'd like to do is now linking the Ebola crisis with the COVID crisis and the COVID response, and what's kind of going wrong with this response. Where have we stumbled here? So some things are pretty obvious, right? The politicization of the response from the very early days in the US. I'll talk a bit about the US first and then the international response. So politicizing it, a health emergency is like the worst thing you can do. It just erodes trust immediately when political actors with their own agenda who aren't trusted by a broad cross-section of society start pronouncing themselves on various aspects of it. It's you're shooting yourself not just in the foot, but like in both legs from day one. If you're going to have politicians who are, it's not just that they don't know what they're doing. They could, if they were trusted and said the right things, it could be okay. But politicizing a response, terrible. And we still haven't recovered from that, right? We still have lots of people in the United States who don't believe the basic science around COVID because the issues were politicized at the very beginning. The second issue, and the US suffered from this so much, there was not a strong crisis management response early on. It was that crazy stuff going out of the White House. It was a bunch of politicians involved. Scientists kind of came in and out. They didn't have crisis management expertise in there. They didn't have the logisticians, the communications people, that total ham-fisted early COVID task force had the wrong people, wrong capabilities there, and it was that what was the pressures being put on them from the White House was not driving them to making good decisions for crisis management of the pandemic, but rather politicized decisions. There were not professionals in key roles on that task force, kind of FEMA type or other crisis management professionals. They just weren't part of those conversations. And also the federal government, I mean, I'm sure everyone knows this, because they did not take did not play a strong role, for instance, around procurement of PPE, masks, testing supplies. It ended up being every state for themselves, and it was a free-for-all where states were fighting against each other and driving up prices of limited supply material. A lot of and that crazy the economics of that drove a lot of unreputable vendors to get involved and start selling low quality masks masquerading as N95s. And so that free for all that existed between the states was really disastrous for state level responders. The communications not only being politicized, but the communications were a mess from the beginning. That they weren't being made with trusted voices. There were mixed messages. And it's okay to say initially, oh, we don't need to mask, and later on say, oh, we do need to mask, if the voices are trusted and the communication is done well and it's explained why, and everyone is kind of on the same message. But when you have, say, a reputable health official saying, oh, actually, we are going to need to mask based on our best understanding of how this is developing, but then you have leading politicians saying, no, don't mask, and the conflicting messages coming out of the same entity, the federal government that's trying to respond, absolute disaster for the response. And again, we're feeling the effect of that to this day. So now maybe a word on the international response, and then I'll wrap it up. So the international response has also been really lacking in my view. There's no international response to speak of, really. There isn't one. It's all just government, national governments doing their own thing. You have COVAX, which has a very valuable role to play as a place to get a lot of vaccines and distribute them. But that is the problem I alluded to or mentioned before, where it's just one part of it. It's not even the whole health part. It's just one part of the health part. And you've probably read about stories of vaccines showing up on tarmacs shortly before they're going to expire, and no ability to distribute them, or sitting out on a hot tarmac and going bad. Governments like South Sudan and DRC sending vaccines back because they can't use them. So the governments did not have the ability to put in place plans to respond to the COVID crisis. Getting vaccines onto a tarmac is valuable, but it's only one step. How are you going to distribute them? Where's the cold chain? Who's going to do the injecting? What about all the training? What about communication to the target population? And this is where the United Nations could have played such a valuable role. It's like a quintessential role for the UN, almost purpose designed, where the UN could have gone about in regions of the world where it would have been helpful, in countries where it would have been helpful, coming up with a standard strategic approaches to, this is how we're going to go after COVID. These are the public health approaches. These are the public health messaging. This is how we're going to deal with vaccines. When can we expect them? Who's going to pay for them? Are we working with the international financial institutions for funding? Or is it foundations like Gates? Or is it some bilateral deal or national budget? Like, where's the money going to come from? What's the timeline for arrival? What's the timeline for training of the people who are going to be doing the injection? How many do we need? Where are they going in the country? There could have been a template strategy for countries with different levels of capabilities that would have been so helpful for so many countries around the world. Instead, every country is inventing the wheel themselves. They are very often undercapacitated, of course, and they are struggling, and there are huge inefficiencies, and no doubt people who have contracted the disease and even died because of those very inefficient approaches. And that's also produced or contributed to, at least, quite serious inequality of access to vaccines and treatments. There's always going to be some inequality, but that inequality is really heightened, I think, because of that lack of strong international coordinated support, bringing together the international financial institutions, the vaccine producers, COVAX, logistics companies who would have been happy to help with the distribution if you asked them and they were approached with a good plan and said, we just need you to do these 10 things or whatever it is. If you channel those kinds of requests in the right way to the right people for things that they can do, they're happy to help. They want to help. But if it's just like random and ad hoc and not coordinated, you're not going to get the assistance that they can provide and is needed. And I'm not suggesting it's easy to do vaccine delivery in rural South Sudan or something. It's not. But with a good strategy and good support from the United Nations and different UN agencies, it's possible. And it wouldn't have been perfect and save every life, but it would have been much, much better than what we've seen. And I believe it would have saved a lot of lives. So I'll stop it there, Lee, and maybe turn it back over to you and see if anyone has any questions.
Thanks, Tony. That was super interesting. And you brought up just the trust. Some of the things you were talking about early on really hit home, at least for me here in Montana. But I want to throw it out there and see if anybody has any questions for Tony right now. And thank you. That was just great. Anybody have any questions? I have. Go ahead, Kimber.
And Tony for your remarks. So I was wondering, I've heard many people who work in the public health sector in sub-Saharan Africa comment on the fact that there was a lower COVID impact in sub-Saharan Africa than initially expected or modeled, say for instance by IHME, is due to the fact that African ministries of health and clinicians are very accustomed to dealing with pandemic type situations or disease outbreaks that are large scale and so forth. And so that kind of differs in some ways from some of the observations that you made about the Ebola response. And I'm wondering if you think this is because, or what you think what you think the explanation is for that gap. Could it be that some countries are really good at it or have developed expertise from lessons learned since 2014, or what do you think about that?
Yeah, it's a very curious issue for sure. And I have wondered about it. I was just in Africa 2 weeks ago in Ethiopia and Kenya. And people are going about their lives. They're masking a bit less than I'm in Washington, D.C. They're masking less than in Washington, D.C., but going to meetings and going about their lives. I really don't know. One possibility that was suggested to me was that the life expectancy in many countries in Africa is lower than, say, in the US or Western Europe. A lot of the people dying of COVID are older with underlying health conditions, pulmonary conditions or whatever. Probably in Africa, a lot of those people with serious underlying health conditions died before they got to 80 and had access to very expensive medicine that was keeping them alive. And so the vulnerability to the community for serious disease and death might be a little lower in Africa than in the US. I don't really think it's because of the familiarity of the various ministries of health with different pandemics, because where there's serious disease, they need treatment, and we know here vaccines are saving lives, treatments, social distancing, that kind of stuff, and it just doesn't really seem to be impacting the communities in the same way. But I don't have, I'm just speculating, and I don't have a well-informed explanation for it.
Yeah, it's really interesting. I think we have time for one more question. Anybody else want to pipe in? Ask Tony one more question.
I will.
Okay, thanks, Gil.
Yeah, so Tony, appreciate your presentation and really hear a lot of the messages you have regarding not just taking into consideration sort of local social and cultural practices and belief systems and how they can be important in responding to an epidemic, but also your recognition that institutions like WHO and other players also have cultures and social arrangements that can impact responses in these sorts of situations. So I was wondering, if you had any thoughts about in terms of the future, how we as public health practitioners and maybe crisis managers, let's just say professionals in this domain in general, how we might go about sort of nudging leadership in a way that makes them aware of their own institutional cultures and how these institutional cultures might present barriers to, achieving effective outcomes.
Yeah, it's such an important issue. You can have really good strategies or tools like vaccines, but if you don't have good leadership, good institutional capability and response, and aren't able to use the tools at your disposal in the most effective way, you can still get very bad outcomes. I think we see that now with COVID. Individuals involved in the response in the U.S. at very senior levels, I think took an approach that ended up having a huge impact on the level of disease and death in our country. I think public health officials have been heroes throughout this pandemic and have again and again communicated so clearly what's happening with the disease, what needs to be done, the impact on health systems, the inequities. But what you're asking is it's a very kind of social issue for the U.S. or even beyond the U.S. Like, how do we get government officials or even institutional leaders to do what we need them to do and what's expected of them? I wish I had the answer to that question. I was in the UN for 20 years, and I finally left just out of enormous frustration that you couldn't get them to do enough of what they should be doing. So it's gosh, I wish I had the good answer to that question. It's something I've struggled with so much, but getting into the right individuals in there, the right leadership, the right culture, the right mentality, those are the really hard things, but they make such a difference.
Thanks, I appreciate that. And that is a tough question. So now more of a softball question. I want to hear a little bit about Lee Taggart in high school.
Oh, no.
I was hoping someone was going to ask. I'll just say two things about her. She was a great athlete, and all the boys liked her.
Thanks, Tony. Phew.
Lee, could I squeeze in a quick question?
Sure, I'm fine.
I think we have a couple more minutes left. Tony, thanks.
Sure.
I really appreciate everything. This kind of connects Ebola with COVID too. So one of the main U.S. response, if I recall correctly, the national response was this a big military intervention, particularly in Sierra Leone. And we see something similar to that with the use of the National Guard here in the United States in terms of COVID. So my question is that crisis management? Would you call that crisis management?
Well, it's an element of crisis response, and what Obama did, deploying the military to set up these treatment units. It was mostly like Liberia. The UK was mostly Sierra Leone, French sort of in Guinea, and the US and Liberia. Using the military version of the public health service. I think it was appropriate response because in a crisis like that, or like the Haiti earthquake or whatever, in the early days, you don't have enough information. You don't know where everything is. You don't know exactly how bad the situation is. You don't know what you're going to need. In Ebola, it's the only crisis I've ever been to, and I've done all these like natural disasters. Ebola, it was the only crisis where you knew tomorrow was going to be worse than today. In a natural disaster response, every day was a little bit better. You get a little more food in, a little more water, reach a little more people. In Ebola, because the caseload was just going up, every day was worse. And not knowing when you're going to break it, the curve, and start to things get better, you had to just throw everything you could at it, everything, just, people, military, treatment units, testing, anything, motorcycles, we were just grabbing everything we could. And given what was available for the US government at the time to respond, and the risks of this getting out of control and spreading all over the place, sending those military teams to set up both engineers to construct it and health professionals to run the treatment centers, that was one of the very few tools at the government's disposal. Now, in the end, a lot of those treatment units didn't get much use. They were placed in the wrong place, or by the time they got set up, we were getting down through isolation and safe burial stuff. So there's a lot of criticism that, all this money was spent, all these people went over there and they didn't have to do that much. But I think it was a very good part of the crisis response. Yeah.
Yeah, interesting. Thanks, Peter, for that last question. So great to hear. Thanks, Tony, for this talk. Super interesting. We could probably keep talking and asking you questions, but I think some of us have to get back to work. I'm actually proud to say that I'm at the Montana Public Health Association conference right now in Helena. So hopefully building systems, making public health infrastructure stronger so that we can be prepared for the next whatever. So with that, I'm going to say thank you to Tony. And I am going to announce next week's lecture, which is going to be Deshane Barnett, who is the Director and Health Officer in Missoula City County Health Department and a doctoral candidate, and at the School of Public and Community Health Sciences. And he'll present the American Indian Traditional Ceremonial Practices Addressing Problem Substance Use in a Multi-Tribal Urban Community. So we're going from very global to fairly local, and it'll be great to hear Deshane's presentation. So without further ado, Tony, thank you again so much. Thanks everybody for showing up, and have a great afternoon.
Thanks, Lee. Thanks,
Hey,
everyone.
thanks, you guys.
Thank you, Tony.
Take care.
Thanks. Bye. Bye, Lee.
Bye.